Okay, so now we're going to talk about caring for the child who's unconscious. So we want to begin with the moment of the emergency, what's caused that child to be unconscious, whether that's trauma, hypoxia, whatever's happened, what needs to be done in that emergent situation. And of course, that's ABCs: manage airway, breathing, circulation, stabilize the spine if it's indicated, because you want to make sure that if there's been trauma, that the spine is stabilized. Manage ICP, remember our intracranial pressure, and find and manage the cause. So if a child is unconscious because of some kind of trauma, those are the things that those are the priorities. So when assessing that child, and this is whether in the emergency or later if they remain in a decreased state of consciousness, you're going to assess their level of consciousness, their pupils, and their vital signs frequently. So we're looking for changes in that coma scale, changes in their level of consciousness. We're looking at their pupils because the pupillary changes can indicate increased intracranial pressure. And we're also looking at vital signs. So remember, the brainstem affects respiratory drive and heart rate and blood pressure, but the hypothalamus affects thermoregulation. So we can have elevated temperatures because of hypothalamic damage. We assess for nuchal rigidity. If the child is unconscious, or if we suspect a neurologic issue, we want to assess for nuchal rigidity. And that means, can they put their chin on their chest? If not, if they can't move their head forward, they may have some nuchal rigidity. That can indicate inflammation or irritation of the meninges. We look at for the presence of protective reflexes. Do they have blink, cough, gag reflexes? We look at muscle tone. Okay, do they have muscle tone? Are they limp and floppy? Do they have excessive muscle tone? We look at posturing, at involuntary movements. Do they have tremors, or do they have seizure activity? Opioid pain meds can actually mask a change in level of consciousness, but if we don't relieve their pain, that can increase their intracranial pressure. So we do need to manage pain because we don't want that child having increased intracranial pressure. For the respiratory system, airway is always the first priority. An oral airway may be used in the initial emergent situation. Oral airways are hard plastic. If the patient is awake and alert, you're not going to get an oral airway in them because it's probably going to cause them to gag. It will trigger the gag reflex if they have one, but it can maintain an open airway by keeping the soft tissues out of the way for a child that's breathing on their own. If they need an airway, but not ventilatory assistance, a nasotracheal or orotracheal airway may be used if they need it for very long, because that hard plastic oral airway is going to cause some pressure injury as well. If they're unconscious for very long, they're probably going to be intubated. Emergency personnel and ER personnel should consider intubation if they have a coma score less than 8, or if they have any signs of herniation, apnea, or if they're having a hard time maintaining an open airway. If they are not able to intubate, or if they have to be on a ventilator long term, then a tracheostomy should be considered. Elevated carbon dioxide, elevated CO2 causes vasodilation, which increases intracranial pressure. It is really, really critical for head injury patients or patients with neurologic injuries to be adequately ventilated. We cannot allow them to get hypercapnic because that's going to cause vasodilation and increase intracranial pressure. Hypoxia for longer than 4 minutes almost always causes permanent brain damage. So that's another reason it's critical to get that patient airway secured and ventilated. We also need to position that patient to prevent aspiration. So if they're not intubated if they are intubated, they still need to be positioned to prevent the aspiration. But if they We want to maintain an open airway, but if in that initial injury, we want to position them in a way while maintaining spine precautions that if they vomit, they're not going to aspirate. And during a resuscitation effort, they need an NG tube to prevent aspiration. If they're not able to manage their own secretions or respiratory secretions, they need to be suctioned, but suction needs to be used only as absolutely necessary because suctioning can increase intracranial pressure. They need to be given oxygen as needed. Remember, we don't want them hypoxic or hypercapnic. Longer term, they may need chest PT to maintain clear airways. And then ABGs are done frequently to guide airway and ventilation needs. In the acute phase of this illness or injury, they may need intracranial pressure monitoring. There are some risks. Anytime we make a hole where it wasn't, there's a risk of infection and hemorrhage. They can also malfunction so that we're not reading correctly, we're not getting accurate information, and they can become obstructed by debris, which again would not allow us to get accurate information. There are different methods for measuring intracranial pressure. An intraventricular catheter goes all into the ventricles in the brain. It allows for measurement and also allows for cerebrospinal fluid drainage. A subarachnoid bolt does as well. There are also epidural sensors and anterior fontanelle pressure monitors that can monitor pressure but not remove some of that fluid. Nutrition, hydration for a child who's unconscious. During the acute phase, they're going to get IV fluid and calories. IV fluids are based on their neurologic symptoms and on their fluid and electrolyte balance. If they're at risk for cerebral edema or if they start to develop some cerebral edema, then their fluids would be reduced. Longer term, if they remain unconscious for very long, they'll move to enteral nutrition with an NG tube or a G tube. The pituitary gland or the hypothalamus may be damaged, and if that happens, that can cause either too much or not enough antidiuretic hormone. So the patient may have SIADH, which is too much antidiuretic hormone, or diabetes insipidus, which is not enough. Remember that with SIADH, they're holding on to all the fluid, which means they're going to be swelling, which is going to include the brain, which is going to cause increase in intracranial pressure. So be aware of that. Thermoregulation. Hyperthermia is common if there's any kind of hypothalamic damage. Antipyretics, so the meds we give, Tylenol, ibuprofen, that we give for fever don't work because this is not fever, it's hypothalamic hyperthermia. So external cooling methods are used, and that's going to involve using cooling, preferably at the pulse points. We want to keep them with as little cover as possible. They use cooling blankets, things like that. Elimination. In the acute phase, they're going to have a catheter for urinary elimination. After the acute phase, that indwelling catheter should be removed because of the risk of infection. And so then that patient may either have incontinence or they may have urinary retention and need intermittent catheterization. Bowel management is with stool softener, suppositories, or enemas as needed. Remember, increased intracranial or increased if they Valsalva, if they are constipated, having a hard time going to the bathroom, that straining can actually increase intracranial pressure. So we want to make sure that they're not getting constipated. Hygiene, we need to maintain skin integrity and give good oral care for infection control reasons. There's a risk of eye irritation, especially if their eyes are not completely closed or if they're getting any kind of osmotic diuretics, because that really dries the eyes out. So we want to make sure and advocate for that kid to get protective ointments. Sometimes the eyes may actually be taped shut at least part of the time, but that protective ointments are really important. That's something that's often overlooked because we're trying to save the kid's life. If we save their life, we'd also like to save their vision. So advocate for eye ointments. Mobility, they need to be positioned to minimize intracranial pressure and prevent aspiration. So we want them elevated. We want the head of the bed elevated. We want to maybe turn them slightly to the side so that if they have any secretions or vomiting, they don't aspirate. We want to make sure that the limbs are supported in neutral alignment with some slight flexion. They need passive range of motion, but we have to watch their intracranial pressure while we're doing that, because if we cause them discomfort, that may increase intracranial pressure. Hands should be splinted to prevent contractions. We used to have footboards on the bed to prevent foot drop, but they're not really as effective as high top shoes. So high top shoes are a good way to help prevent foot drop, but make sure those are being removed and the skin's being assessed frequently. We want to provide stimulation for all the senses for a child or any person who's unconscious for a length of time, especially familiar stimuli. But in the acute phase, we have to balance that with the concern for intracranial pressure. So we've got to be careful not to overstimulate. That's familiar stimulation, familiar stimuli can help that child return to consciousness. Auditory sense is the last to be lost and first regained most of the time. So we need to be cautious about what's being said in that child's presence, and we need to warn families to be cautious about that. Regaining consciousness usually occurs gradually. It can be stressful and frightening for a lot of kids. Kids may respond by withdrawing or by having personality changes. So parents need to be aware that when their child's not just going to magically wake up and be themselves like in the movies, that it's a gradual process, and there's usually some trauma involved. We also need to be providing support for that family. Parents may feel guilty about their child being ill or injured. They may be afraid of losing that child. That may come out as hostility toward each other, toward other people, toward the healthcare staff. They may have a lot of anxiety. The outcome is uncertain, and we need to be careful about not providing inappropriate hope, not providing false hope. We need to be to provide honest information. If the child doesn't regain consciousness, parents may start bringing things from home that are familiar, partly to try to stimulate that child to wake up, but also to reconstruct the child as they knew them and to show the nurses that child as a person. Parents will mourn the child that they have known, even as they're trying to care for the child they now have. There also can be some difficult ethical decisions at times. The child may not have much potential for recovery. So parents may have to make ethical decisions about code status. Sometimes either brain death or persistent vegetative state may have happened. So there may be some ethical decisions in this area. The child may regain consciousness, but they may have neurologic deficits, and so the parents have to be prepared for that. Parents may choose to take their child home or to place them in residential care once they are past the initial acute phase of that injury or illness. Okay, next we're going to talk about seizures.